Dr. Raman Mittal, Dr. Saurabh Mittal, Dr. J.S. Gumbar, Dr. Munish Dhawan.
Dr. Madam Bohra is not there? Okay, it is first day and nearly the first session, so of course the attendance is poor, but we have to honor the time. So may I call upon our first speaker of the day of this session, Dr. Shikha Taneja. She will be enlightening us about the botulinum toxin uses in ophthalmology and maybe around the face as well. Dr. Shikha.
Morning all. Thank you. I'd like to thank the organizers for this opportunity. I shall be talking about botulinum toxin and its uses in ophthalmology. As we all know, it is actually a neurotoxin produced by Clostridium botulinum bacteria, and it acts at the neuromuscular junction, inhibiting the acetylcholine release, thus causing paralysis of the muscle. But its activity lasts just for 3 to 4 months. That is because there occurs sprouting at the nerve terminals and re-establishing the neurotransmission at the NMJ junction. There are various different forms available, different forms in the sense the protein is purified in a different manner. Different companies are there. The one which we commonly use as Botox is actually Allergan. I have no financial interest in any of these brands. I commonly use this Botox brand. It comes in 2 vials, that is 50 units and 100 units. It's a freeze-dried powder form. It has to be stored under less than 8 degrees, and it is usually reconstituted, it is reconstituted with normal saline solution 0.9%. We usually aim for 2.5 units per 0.1 ml. So we actually dilute it with 2 ml of NS. And as you can see, it's a vacuum sealed bottle, so I don't have to push the plunger. We have to be very gentle while reconstituting because we don't want the molecule to break. It's a fragile molecule. And once reconstituted, it has to be stored at 4 to 8 degrees, that is door of the fridge. And it can be used up till 4 to 6 weeks, as studies have shown. But the company suggests up till 4 hours after reconstitution. So when we look at the uses, there are multiple uses, functional as well as cosmetic. Functional, it can be used in the entire range of spasms, strabismus, upper eyelid retraction, entropions, epiphora, and cosmetic for all the lines on the face, we can use it. Coming to the spasms, what we need to understand is that all the spasms is usually acting because of the co-contraction of the agonist and the antagonist muscle. So whenever we are seeing any patient, the first step is to imagine which all muscles are actually overacting and target those muscles. So if you carefully look at this lady, this is a case of hemifacial spasm on the right side. There is definite contraction of the orbicularis muscle, and if you look carefully at the brow, the corrugators are also contracting and pulling the brow down and medially. The angle is being raised because of the zygomaticus. And one important muscle which all of us should actually target in HFS is this levator labii superioris aliqua nasi, which sorts of lifts the upper lip centrally. Apart from that, the spasm can actually spread inferiorly up till mentalis platysma. Depending on the patient, we need to target which muscles. So the first step which I do in the OPD once the patient comes to me is clean the face, then mark which all points I want to target actually. And then I anesthetize with Prolox ointment, and that's when we start with the injection. So usually 15 to 30 units of reconstituted Botox is being used, and we aim for 0.1 cc at each site, giving almost 2.5 units at each site. Now orbicularis muscle is essentially a very, very superficial muscle lying just underneath the skin. So we go flat on the eyelid. Usually I use 30 gauge needles. People also use tuberculin syringes, whichever is convenient can be used. And we aim for this bleb formation so that we know that it's actually going into the muscle belly. Next, when we come to the lateral end, try staying away from the lateral orbital rim. That is slightly lateral to the lateral orbital rim. This will decrease chances of diffusion into lateral rectus muscle, as you can see. Next, coming to the corrugator, I always try first palpate the corrugators and then, sort of I manually keep my finger around the rim. This also manually, you're inhibiting diffusion into the LPS muscle, just preventing ptosis. Its effect usually lasts for 5 days, effect lasts for 3 to 4 months, but the peak effect is seen around 10 to 14 days, which we need to counsel our patients prior only, because otherwise you'll start getting calls next day onwards itself. A word of caution, avoid preseptal orbicularis, they are higher risk of ptosis, and also avoid extreme lateral end around the brow, because we're going to block the frontalis and causing brow ptosis in this case. Next, coming to benign essential blepharospasm, we usually use 35 to 50 units, can go up till 60 units as well. Begin with the lower dose and then gradually step up, catering to the patient's need. In blepharospasm, what happens is our brow droop is very strong. The brow depressors are acting very strongly, so target these procedures and corrugator nicely to get a better result. Apart from the orbicularis, target the corrugators and procedures as well in case of BEB patients. Coming to our now aesthetics. So why is actually all these horizontal lines occurring is because understand that facial muscles have some connection with our skin. They are either inserted directly or through certain fascia. So whenever there is contraction of the facial muscles, along with that, our skin is also moving. And when the skin is moving, eventually it loses elasticity and we end up with all the lines. But Botox is effective in dynamic lines. That is, when we get all these crow's feet when the patient is smiling or talking, once they become static, the effect goes down. You can soften them up, but you cannot remove them. So counsel your patients accordingly. In case of crow's feet, what you see actually is because of the vertically oriented orbicularis muscle around the lateral edge. Because the muscle contracts in vertical direction, we get horizontal lines. In Indians, we do not have very pronounced crow's feet. So usually 2 to 3 sides are more than enough. Each side you give 2.5 units. Avoid going up till the zygoma because we have a zygomaticus muscle insertion around this area. Again, we might affect the smile of the patient. Coming to the glabellar rhytids or the 11s on our forehead, again, the best way is you ask the patient to squint. When you ask the patient to squint, your corrugator becomes very pronounced and you mark the lateral edge. Right after that, you go ahead with 2.5 units at each end, as I had explained earlier. Coming to the forehead rhytids, go ahead, mark the lateral and the medial edge. So that is the junction of the frontal and the temporal bone, and spread it out, fan it out. Do not concentrate the Botox just centrally, because otherwise we might end up with spoke deformity, because the lateral edge of the frontalis muscle would be pulling up the brow and you have already paralyzed the central portion. So make sure you spread it out. Apart from that, good usage would be in case of upper eyelid retraction, where you want some sort of temporary effect. We can give 5 to 10 units of Botox transcutaneously, transconjunctivally, and also lacrimal gland Botoxes, which we use in cases of epipora, which can also be because of bicanalicular blocks, which cannot be treated. In the end, I'd like to just say that always visualize the muscle. That is the most important thing. Palpate, take your time, make videos, and then go ahead with the injections. Always record their pre and post videos. It really helps. And also, do not chase the line, chase the muscles. We are not chasing the wrinkles. Thank you.
Thank you, Shikha. That was a wonderful summary of what all we need to do in Botox. Before I take up the next talk, I would like to invite formally our former president of Oculoplastic Association of India, Dr. Abhijit ma'am. She has taken out time to come up all the way from Lucknow, especially when there is no direct flight to Lucknow to Amritsar nowadays. Thank you, ma'am, for being with us.
It's my pleasure. It's on. My pleasure being here. Dr. Shikha. Huh? So, Shikha, I just want to add two things to your presentation. First is that our confidence should not become overconfidence. So, never inject without protecting the eyelid. I was noticing that when you were injecting, there was no eyelid support. So suppose the patient winces or squeezes, so always have some, either a shell or a lid guard. Anything. If a shell is not easily available, use the usual lid guard. But always keep your eyeball protected, and while protecting the eyeball, ensure that you don't stretch the lid. So that is an important thing. So why the lid should maintain its normal anatomy. Simultaneously, you should protect the eyeball. The second thing about crow's feet was that it would be an overstatement to say that Indians don't have very prominent
lesser
crow's feet, because crow's feet has a lot to do with actinic exposure also.
Correct.
So if you see people who live in the hills, who are exposed to more actinic radiations, so they have thicker and more refractory crow's feet. So they are not as simple
as that. Yeah.
Thank you.
I have one doubt. Till how long we can keep injecting, Botox in the patient, especially with benign essential blepharospasm?
So this is something like you have to take a call. Sometimes when you think that it is benign this patient sometimes has an underlying pathology on the Gasserian ganglion. So when you feel that it is, you're not going to permanently take it out. So before you embark upon your treatment, you must always do an MRI if you think that the patient is not just classically benign essential blepharospasm. Yes, secondly, how long to go on with it's like a lifelong thing. There are no drugs, but yes, Pacitane and other drugs which sort of calm the patient can be used in addition under neurological guidance. So most often for very severe cases, I do add Pacitane to it.
Ma'am, any experience with using Dysport? Like we are usually using Botox.
I don't use Dysport.
Dysport is not very much in vogue or in fashion, you can say, in this part of the country. In England and all those parts, they use Dysport quite a bit. So now it has started being marketing in this our country as well, but not much is catching up. In cases where patient has become refractory to botulinum toxin, then you can change the molecule and you can go towards Dysport. One simple word, as Madam has mentioned, apart from those cautions, if you are starting a patient afresh and you have to calculate the dose, always err towards minimal dosage. You can always add upon the doses, rather than if you give a complete full dose, you can't take it out. So sometimes they land up into much of paralysis. And in hemifacials, avoid the perioral areas in the beginning.
Dr. Shikha, what all areas, specific areas on the face to be avoided, we need to be careful before injecting? And secondly, have you found any permanent side effect of these Botox injections on the face other than local factors, local side effects? Any systemic side effect you have noticed?
No, systemic side effects, frankly, I haven't noticed. Yes, if we always overdose the, Botox injection and completely keeping our muscles completely paralyzed of the face, understand our frontalis, even if I'm not raising my brow, but it has some resting tone to it. That is why my eyebrow is lifted. But if we completely paralyze it all the time, it actually leads to, loss of activity of that muscle. There can be that mask-like facies, and eventually because of that loss of resting tone, you can have brow droop and all. That can happen. And if you ask me about specific areas where I would ask everybody to be very careful is, again, just above the lateral brow, because we do not want to inject around this area. In the sense, the patient might end up with brow droop. definitely around the angle of the mouth, because we don't want that area to be injected. We have 8 muscles joining around this area, and there can be drooping of the angle. Around nasalis muscle, because then again your entire nasal vestibule will collapse, and again breathing problem can be there. And again on the zygoma, be careful when you're injecting the zygomaticus major or minor, because it can eventually affect the smile and patient can come to you with that complaint. So these are specific areas which I would say. And of course the supraorbital, supratrochlear area, because the vascular medial edge of the area, because the vascularity is there, so just be careful around that. You don't want to end up giving patient bruises and all.
Thank you, Shikha. That was a wonderful insight in botulinum toxin. Before we go in for the next talk, Madam Bohra, please be on the chair. You are a chairperson. I am vacating it. Please come. Please be here. We'll put, but first you come. Next talk. I'm also going to give the next talk. I'll be talking about some myths in ptosis. Dr. Raman Mittal. So first of all, I welcome you all to this conference. It is, I think, for the first time that the midterm is being organized, a national level conference in this part of the country. Earlier, long back in the days of Dr. Diljit Singh, there was an AIOS conference held in this Amritsar. So this talk is basically targeted towards general ophthalmologists, but here I see they are more of oculoplastics and pediatric ophthalmologists, and they know more of what I'm trying to convince the general ophthalmologists, because there are few myths amongst the general ophthalmologists for the reasons they do not either refer in time, or they misguide the patient, or they would sometimes incorporate such disbeliefs in the patients that the patient becomes very fearful of getting the ptosis surgeries done even at a later stage. So I'll try to address them one by one. We all know what ptosis is, about the drooping of the lid, one or both. It could be congenital or acquired. This is simple congenital ptosis, and an LPS resection can give you a good result. Can I have a pointer if possible? Pointer. If we have a poor LPS section, then we go in for a sling surgery. So the first myth, what I'm going to address, is the age of the patient. Most of the doctors, even our colleagues, think that ptosis cannot be operated at a very early or a very late age. So this is very common problem that we encounter when a young person comes and we ask them why you didn't get a surgery done. He or she would have been told by some very prominent names in the city that don't get it touched even before the age of 15 or 18. So that is something which is wrong, and it is a wrong information, I would say. The fact is, an ideal age for ptosis correction is preschool going age, like this chap, but even we can operate at an earlier age if the risk of amblyopia is more and the pupil is covered. Like is then in this girl, she was about 1.5 years of age when she was brought to me. Now you can see she is a bilateral ptosis girl, hardly any fissure is there, she can't see. So of course she will land up into dense amblyopia, or she had a head tilt. Doing a bilateral tarsofrontal sling, you can see the results are very nice. The post-op results are perfectly fine. And it can be even operated at a very late age, like this. He was a chap of 90 plus years. Some people think that at a very elderly age should not be subjected to any surgeries and whatnot. But see the comfort which this gentleman would have after the ptosis is done. Otherwise he is in a constant brow lift position, and that is also very tiring for this age group. So that relaxation can be achieved only once we do the surgery. Second myth is about Marcus gun phenomena, that it cannot be improved without doing a bilateral surgery. This we discuss in the morning session also. This is the Marcus gun jaw winking phenomena. When you move the jaw, there is a lid excursion. Though the fact is that MGP can be reduced considerably even after doing a simple ptosis surgery. Like in this lady, she is having a Marcus gun, but very nice correction and very much reduced Marcus gun phenomena post simple LPS surgery. In this again, she had Marcus gun phenomena, which got reduced after doing a sling surgery. So whether you do an LPS or you do a sling, you get a benefit in Marcus gun phenomena. So there's no need to bilaterally excise the LPS and then do a bilateral sling surgery. Third myth is that a ptosis surgery leaves an ugly visible scar. Sometimes the patient come and they have a ptosis, considerable ptosis. Punjabi च कहने इन्ना ptosis है कि दूरों दिखदा किलोमीटर तो, but they will be wearing इस निशान तो नहीं रह जाएगा जेड़ा कि पता नहीं लबना भी है कि नहीं. So hardly there is a scar, and even if there is, it is very, very negligible. Like in this marriageable girl, you see LPS has been done where we incise the lid from about middle canthus till up to the lateral canthus. Hardly any scar. So having scar after surgeries is a myth. This area is a very forgiving area. In this girl also you see that there is, what is this noise? Okay, in this there is no scar and very good lid movement. Third myth is the patient won't be able to blink. They say that the आँख खड़ी दी खड़ी रह जाएगी जी, blink नहीं होएगा, सानू यह किया गया कि आँख blink नहीं होगी. Again, there is hardly any problem in the blink. Here no scar, and you see the blink is perfectly fine. It was done in LPS. So when you do a good LPS surgery, you hardly distort the anatomy. Of course, in sling surgeries, there could be some discrepancy in the blink rates. But if it's a bilateral sling surgery, then again, the blink is very good. This chap underwent a bilateral sling surgery. So you can see the symmetry is perfect, hardly any scars. The closure is good enough. So these all are myths which are unfortunately incorporated in the minds of the patients, and they are fearful of coming. So this video shows that even in a child of about 3 years of age, the patient can blink or forcefully close the lids. Of course, this is just 1 week post-op. This I show them stating that if within 1 week and this age group of child is able to close the lids, why not an adult or even this child after a few days? This lid lag is something which we need to counsel them about, which will be there in 100% of the cases, and then you have to tell them to move the chin down while looking down. Fifth myth is that the eye remains open while sleeping, nocturnal lag of ophthalmos. Of course, there is some part of nocturnal lag of ophthalmos which we face, especially in sling cases, but in LPS there is hardly any nocturnal lag off after about 1 to 3 months. This is one patient in which sling was done and she has a minimal nocturnal lag of ophthalmos, whereas the other child has no surgery done, and some people sleep with their eyes open. So nocturnal lag of ophthalmos may be more prominent in a normal patient or a child than in a post-operative case. But once you have touched the eye or done a surgery, सारा ध्यान उस तरफ शिफ्ट हो जाता है कि जी ये हो गया वो हो गया. उससे पहले चाहे जो मर्जी होता रहे, आधी दुनिया ने तो नोटिस ही नहीं किया होता कि टोसिस भी है. So these are the few things. This was earlier. Thank you for coming here and visiting this conference. Thank you very much.
Thanks, Raman, for this wonderful talk. You really covered everything. Just a point that in the first child, that appeared to me to be a BPESS.
First child.
So because there are bilateral epicanthal folds and there was a telecanthus. So maybe sometimes when children come with bilateral severe ptosis, you need to look at the canthal positions and the lid folds. That's one. And eponeurotic ptosis, of course, will always be in elderly. So the myth that he said that ptosis can't be operated in old age, eponeurotic ptosis is 9 out of 10 going to be in old age. Only if it's traumatic, it will be in the younger. Then for Marcus gun, Raman, my practice, I've seen that if you do an LPS resection, actually the Marcus gun worsens. So I like to disinsert the LPS on that side and put in a sling. So if you're doing it bilaterally, then maybe, because the change is going to be the same, then you may just go in, because whatever enhancement is going to happen will happen. But with sling, it does better in my hands as compared to the LPS resection.
Ma'am, of course, your experience is much more than what I have. but somehow I have figured out that in most of my cases, even if I do LPS, I have found that the excursion, because earlier I was ptotic and it is rising to a level, for example, from a height of 5 millimeters, it's going till 11, so the excursion is 6. Once you raise it to about 8 or 9, the highest point where it can raise is 11, 12 only. So the
Yeah, but
excursion
that
total.
LPS is much stronger now.
Mhm.
So that innervation, again, see, the Marcus gun is happening because of the aberrant innervation. So once you are strengthening the muscles, the neuronal impulses are also going to increase, as happens for any squint surgery. So if you strengthen the LPS, its propensity to move more will increase. That's what I noticed. Take a mic.
Can I have the free mics, floating mics in the auditor? Switch it on, the audience mic, please.
Yeah. So basically what I do is I actually sit and spend a lot of time with the patient finding out what is their primary concern. Is it the ptosis or is it the Marcus gun jaw winking? If it is Marcus gun jaw winking, then I go ahead with the sling and excising the muscle. But if it is just specifically ptosis, because in my hands the LPSR gives much better cosmetic correction. So I go ahead with
Agreed.
that.
Amount of jaw winking is the primary actually in deciding what procedure you will choose. That makes a point. Yeah.
Dr. Raman, there was a Babaji with the ptosis, aponeuritic ptosis with the, there was also squint there. So what do you prefer doing, squint first or ptosis first?
See, if the squint is sometimes intermittent, which on ptosis correction unilateral cases, sometimes because there is a poor fixation, the squint is prominent, but once you lift the lid, the squint is getting corrected. In those type of cases only, I would prefer doing a lid surgery. Otherwise, yes, by dictum, squint should be done before, because a part of ptosis is corrected by doing squint. Especially if it is a hypertropia, then there is no doubt you have to do squint first. But if it's a horizontal squint, then you can sometimes address depending upon the how much squint is, how much of the ptosis is there, what is being concerned by the patient. You have to document it well. Sometimes the patient is not aware of that subtle squint which is lying under the ptotic lid. So once you have the snap and tell them, okay, fine, I'm going to correct it, and you already have a squint. It's not that I'm going to induce it, because after you correct the ptosis and the squint becomes prominent, the patient may say, "Ate aak teddy karti ji pehlan to theek si."
That concern is very important because we get so many patients with both squint and ptosis also together.
Perfect.
And second, last comment only, the rapid eye movement takes care of the dryness which is there with the lag ophthalmos in night.
Sorry, come again.
The rapid eye movement in night takes care of the dryness part or the exposure. So we are not that much worried about the lag ophthalmos.
Very true, but the patient's concern is कि भाई रात को आँख खुली रहेगी. So जब कोई अटक जाता है उस बात पे, तो न ऐसे कि रात को ज़्यादा इम्पोर्टेंट है देखना कि दिन में सारी रात, सारा दिन, सारी जिंदगी आँख नीचे है, वो ठीक है. रात को तो किसी ने देखना नहीं.
अटके हुए पेशेंट का कुछ नहीं कर सकते.
Thank you, Raman. Can we go on to the next talk, please?
Diagnosis and the various treatment decisions. Harpreet Singh Migla.
Good morning, and thank you AIOS and POS for giving me this opportunity to be here. So Duane's retraction syndrome is actually a very vast topic, and in the limited time allotted, I'll be mainly discussing about the management strategies of the different types of Duane's. So Duane's retraction syndrome is a congenital motility disorder caused by the absence or partial development of the abducent nucleus or nerve and a variable amount of disinnervation to the lateral rectus by the oculomotor nerve. So it's a truly congenital condition
Just arrived.
caused by disinnervation of the cranial nerve, hence it has been subgrouped under the title of CCDDs, that is congenital cranial disinnervation disorders. So you get a variable amount of abduction limitation or adduction limitation, or sometimes both. There is an abnormal head posture primarily to maintain the binocular single vision and compensate for the adduction limitations. In case of isotropic duanes, it will be to the same side, and in case of exoduanes, it will be to the opposite side. And characteristically, kind of hallmark of duanes is narrowing of the palpebral fissure on adduction and widening of palpebral fissure on abduction. And along with that, there may be upshoots or downshoots, which are mostly because of the mechanical effect of the tight lateral rectus, called the leash effect. It's because of the globe slippage around the tight lateral rectus, and sometimes it can be innervational also because of the co-innervation of the vertical muscles and the medial rectus. And you get strabismus also, ranging from esotropia to orthotropia to exotropia. And it is important to be aware of the fact that apart from the classical presentations, duanes can also present in some atypical forms, more rarely though, like duanes minus, in which you don't find all the features of the duanes. Synergistic divergence is an extreme form of exoduane, also known as the type 4 duanes or ocular splits. Vertical duanes because of the co-innervation of the vertical muscles, and also all sort of patterns can also be present. So coming on to the management part of various types of Duane syndrome, we all know that Huber's classification has been the most popular, but from management point of view, the most practical classification is based on the clinical features of Duane's, primarily the primary position alignment, either iso or orthotropic or exotropic, and taking into consideration all these features, the retraction, the amount of retraction, the upshoots or downshoots, and the limitation of abduction or adduction. The management is primarily operative in cases of Duane syndrome, but it is important to realize that there is no perfect method of treatment and no real cure in Duane syndrome. You have to individualize the patient, the treatment on a case-to-case basis, because normal nomograms do not work here. And the main points already said to consider are the primary position deviation, and then you have to see the range of the adduction limitations, the severity of the retraction and the associated up or down shoots, and the range of binocular single vision present already. So the most important point probably is in the preoperative workup is to diagnose the extent of the co-contraction, and the various clinical features that give us a clue to the presence of co-contraction are these typical features: narrowing of palpebral fissure on adduction, that is because of the co-contraction of the medial and lateral rectus, and widening on abduction because of the co-relaxation of both the muscles. Then presence of up or down shoots, the limitation of adduction, then iso, distance near disparity, iso more for distance than near, or exo more for near than distance, and exotropia in adduction on cover test. And apart from that, you can have a forced adduction test, and a forced degeneration test is particularly for Duane's. This is to diagnose the co-contraction of the lateral rectus. You feel the resistance by the lateral rectus on adduction, but not on abduction. That is kind of opposite to the forced generation test. So the only case, probably the least severe form of Duane's, is when you get an orthotropic Duane with no or minimal head posture and almost no retraction. This is a case where no surgery is indicated, but again, as in any case of squint, you have to look for any amblyopia and refractive error and treat it accordingly. So in all other cases, like the indications for surgery are the noticeable deviation in primary position, the anomalous head posture, significant retraction or co-contraction, and the presence of up or down shoots. So for esotropic Duane's, as with any case of strabismus, especially esotropia, you have to rule out any accommodative element, and there is a subset of esoduanes which you can find, which can be corrected with the proper prescription of the hypermetropic glasses, and not even the angle, but also the head posture also can sometimes be eliminated. But otherwise, for a small esotropic Duane, say up to about 20 prism diopters, but with minimal or no co-contraction and a minimal head posture, if the FDT of the medial rectus is negative, then you can straight away go in for a superior rectus transposition or a vertical rectus transposition, which can correct to some extent the amount of abduction limitation also. But if the medial rectus is fibrotic or the FDT is positive, then the primary treatment is a medial rectus recession. And you have to be careful while doing medial rectus recession that it has to be minimal according as per the FDT and not more than maybe 5 or 5.5 millimeters. Because larger recessions can very easily land up in consecutive exotropia, or in severe cases if you have missed the co-contraction before, then it may even cause an iatrogenic synergistic divergence. For a little larger angle, say 25 to 30 prism diopters, but again if the co-contractions are minimal, then a biomedial recession can be done. And of course in the Duane's eye, the medial rectus recession has to be minimal, while in the other eye it can be larger. Or medial rectus recession can be combined with the superior rectus transposition. And in some cases like these, you can even, some authors have done a resect procedure also, whereby you resect a small amount of lateral rectus. Although generally in Duane's cases, resection of muscles is to be avoided or has to be done very carefully. And here also the resection should not be more than 3.5 millimeters, otherwise it can worsen the co-contraction. But if the Duane is associated with significant co-contraction or up and down shoots, then you have to take care of this co-contraction also by doing a recession of both the lateral and the medial rectus.
Could you please hurry up? Time
Sure,
is almost
sure.
up. Please wind up.
So, coming on to the orthotropic Duane, simple orthotropic Duane with no co-contraction, no surgery, but if it is associated with co-contraction, then again you have to do a differential recession of the medial and the lateral rectus, with or without eye splitting, depending on the presence of up or down shoots. And lastly, for exotropic Duanes, with a small angle, a single LR recession alone should be sufficient, or you can do a bilateral recession depending upon the angle. But again, if there is co-contraction or severe retraction present along with, then you have to combine the LR recession with a Y split. Or in extreme cases, you can do a periosteal fixation of the lateral rectus, and then superior rectus or vertical rectus transposition can be added to improve abduction. So, we have to understand that Duane's retraction syndrome is a spectrum of presentations, and the management varies on a case-to-case basis. Most important is to diagnose the co-contraction and address it properly. Resection of lateral or medial rectus is generally to be avoided except in very small cases, and have to choose it carefully. Medial rectus recession should be minimal. Lateral rectus recession can be slightly larger, maybe up to 10 millimeters. And Y split, if you have to do, both the arms of the Y split should be at least 20 millimeter apart to be more effective. And there is no harm in doing a stage surgery. So the most important thing is to do a proper preoperative counseling, and you must give a realistic prognosis to the patient. You have
So
to give
may I
a proper
request
care
you to
time.
please wind up?
Yeah, sure, ma'am. So you have to just explain to the patient that surgery does not eliminate the fundamental abnormality of innervation. Thank you. Thank you.
So we request all the participants, all the speakers to please maintain the time because the other session gets late. So next we call upon Dr. Saurabh Mittal, Understanding Strabismus through various case presentations.
Before he comes, Dr. Miglani, just want to ask you one question. So which technique according to you works best in your hands, especially for isoduanes? So you have mentioned different techniques for the
Yes.
treatment.
So I haven't done any vertical transpositions for Duane's cases, although I've done it for the sectional policies. But simplest and the easiest is again the medial rectus recession. And in cases of, especially in cases of Duane's, it is always better to do a minimal surgery and give better to be on the under correction side.
Actually, I find it very difficult, especially for when the medial rectus is tight. So I always try doing hang back technique in such cases. So that works very good, because muscles, they are so tight and it's sometimes very, very difficult to handle the muscles. Have you tried hang back
No,
technique?
I have not done hang back for duets, because, and I think you should actually not do it, because in hang back you are not very sure of the actual position of the medial rectus, and medial rectus recession is actually fraught with the risk of getting overcorrection. It is very difficult to overcorrect an exoduane, but it is very easy to overcorrect an esoduane.
Okay.
It should be minimal.
Okay. Sir, Mike.
In handbag, you whatever handbag you want to do, you apply a muscle, a suture there. So it doesn't, handbag problem is it comes forward. You apply two sutures on either side of the muscle, it will not come back.
Especially in case of tight MR, the right hook is very useful. It has a groove in between, and you can once you put it under the medial rectus, you can, with the groove, you can put on the sutures. It is less risky as compared to the
Okay, thank you.
Okay, we can continue the discussion during the lunch hour. Dr. Saurabh, please continue.
Good morning, everyone. I thank AOS for the invite, and today I will be just talking about strabismus, the basics of strabismus, and the treatment options.
Please get closer to the mic.
So, what we will be discussing today will be how to make a diagnosis, how to plan a treatment, follow up, and learn and refine the surgeries. So, making a diagnosis, we should know what the exact history of the patient is, general inspection. We should be evaluating the motor functions. That is very important in any strabismus surgery, because if we don't evaluate the motor functions, we are not going to treat the patient at all. We should also know about the sensory functions, that is the vision and the refraction, and we should also along with do the ocular examination. So making a diagnosis is very simple. If the eye is in, it is esotropia. If the eye is out, it is exotropia. If it's up, it is hyper. If it is down, it is hypo. What is exotropia is basically when the eye is outwards. Then there are different types. If the near deviation, that is at 1 meter, is equal to that of distance, it is called basic exotropia. If the near is more than distance, it is called convergence insufficiency. If distance is more than near, it is called either true divergence or a stimulated divergence, depending upon if the distance deviation is more than near after a patch test, it is true divergence, and if it is near deviation which is more than the distance deviation, it is stimulated divergence. Esotropia can be congenital or it can be acquired. If it's seen with a history less than 6 months, it is congenital. More than 6 months, we put it into acquired category. Esotropias of congenital can be infantile, and it's one of the most common type of esotropias. Congenital esotropias, if there is also a limited abduction, then it can be Duane's or it can be sixth nerve palsy. Duane's, Dr. Miglani has already discussed. Esotropias can be acquired, and if there is a decrease in vision, it can be sensory esotropia. If there is high hypermetropia, it can be refractive. If there is high AC by A ratio, it is a convergence excess type of esotropia. So esotropia can come with limited abduction. So if the passive movement is full on forced duction, it can be acute sixth nerve palsy or a slip or a lost muscle. If the passive movement is limited, it can be an endocrine disorder or it can be a tight medial rectus. To proceed with the diagnosis, how to make a diagnosis, we do some baseline evaluations, especially with the help of prisms or synaptophore. Synaptophore is obsolete, we normally use prisms now. We also measure the sensory functions. We identify the associated conditions along with the squint, and we also identify what factors are going to influence our results. So multiple factors can be there with just esotropia, exotropia. There can be inferior oblique overaction, or there might be some upward or downward movements in right and left, which can be called as X, Y, A, all different patterns. So everything has to be noted down, and we should always document our baseline photograph, because that is very important when the patient comes back to you and asks you, sir, farak hi nahi paya. So then that baseline photographs helps a lot, and also it builds up the confidence with the patient that you are going to do a very good surgery. So plan a treatment. Basic target is orthophoria or asymptomatic heterophoria, which is less than 5 prisms diopters. Normal visual acuity, normal stereo acuity, normal retinal correspondence, and a stable sensory and motor functions. The treatment options: first is find out what the refractive error is and prescribe the refractive error. Most of the patients, they do turn to have a very good result because of the correction in the refractive errors. You can give some exercises or do occlusion therapy, but exercises, I have finally found out that doing exercises take a lot of your energy, and the end result is that we have to go for surgery. Surgery is, if you do a muscle weakening, it is called recession, and if you do a muscle strengthening, you do a resection. Resection, you cut the piece of muscle and just bring it forward. Recession, you just move the muscle from the original insertion a little backwards. And then you can do a muscle transposition depending upon the case. So which eye to be operated, how much to operate depends upon the doctor and the surgeon, and there are step guidelines which are there given in each and every textbook, which we can go through, and according to that we can decide what surgery has to be done. Also we have to customize our surgery depending upon what we want the final result to be. You can undercorrect, you can overcorrect, you can do a muscle shifting, you can do a muscle transposition depending upon what you have initially. So surgical plan depends upon all these associated factors. I am not going to discuss them. Patient counseling is very important because you are going to get some amount of diplopia which can be there for initially few days, or it can last a little longer. So you have to tell the patient about the diplopia after surgery. And also about how to correct the vision if there is a vision is decreased. So amblyopia management also has to be discussed. Lot of patients ask that glasses bhi utar jayenge, so glasses will stay. That we have to tell the patient that glasses is going to stay. So finally we have to do many surgeries, find out what results we are getting. So we have to learn from our surgeries, learn from the published reports, and then refine on the next patient what you are going to operate. So decision making, I am going to just show some cases and discuss the treatments what we have given and see the results. This 23-year-old male, left eye vision is 2/60. The deviation was 35 base in, and which was equal for distance and near, and there was alternate fixation. Other things were all normal. So diagnosis was basic constant exotropia or divergent squint. The surgery was done in the left eye. The lateral rectus was recessed for 7 millimeters, medial rectus resection of 7 millimeters. We have to wait for 3 to 4 months to find out exactly what is the end result of the surgery, and if required we can do the other eye surgery. So target will be mild overcorrection to achieve the orthophoria with time. The case 2 is 21-year-old male, vision is 6/6 in both the eyes. Here the distance deviation is more than that of the near deviation, and on doing a patch test we found that the distance deviation was again more than that of near deviation. Other things were all normal. The diagnosis was true divergence excess exotropia, and the treatment was bilateral recession of 6 millimeters in both the eyes, and the target was to have a slight overcorrection or orthophoria after surgery. Case 3 is 1.5 years of male, present, started with squint at 9 months of age, vision was 6/12 on Cardiff. The deviation was 35 to 40 prisms base in, which was equal to that of distance, and there was inferior oblique overaction. Here we have to see very closely that there is any inferior oblique overaction or not, and that has to be addressed at the time of primary surgery. So diagnosis was basic exotropia with bilateral inferior oblique overaction, and the surgery was done was lateral rectus recession in both the eyes and inferior oblique recession in both the eyes, and the target was to have orthophoria. The conservative treatment in those cases will not help. Now in this type of cases where there is a refractive errors also, we have to start with the glasses and then we have to proceed with the surgical options. This 5-year-old male had onset less than 6 months of age. Less than 6 months means it's a congenital type. The distance was almost equal to near, and that was base out 45 prisms, and there was left inferior oblique overaction which was there in the right extreme gaze. So diagnosis was infantile exotropia, and the treatment done was in right eye, medial rectus recession of 5 millimeters and lateral rectus resection of 9 millimeters. The target was to have little bit of undercorrection, because with age the eye is going to, the face is going to grow, and I have seen that if we completely correct these patients, they are going to they have a tendency that they might go for exotropia with time, and also this child has mild hypermetropia, so undercorrection was targeted, and The rest of the correction, probably with glasses, would take care of the deviation. This case 5 of 7-year-old female, refractive error was plus 4.5 in right eye and plus 5.5 in left eye. But the deviation was more for near and was more.
Dr. Saurabh, please wind up.
Yes, ma'am. So this patient's this was called refractive accommodative esotropia, and it was corrected with glasses completely. This case where there was a refractive error of 3.5 and there was a deviation of 50 prisms base out, which was more than that for distance. AC by A ratio was calculated, which was very high. These were convergence excess type of esotropias. Glasses were given, still there was esotropia. These patients require surgery after some time. So the inferior oblique overaction, if it is only inferior oblique overaction, just inferior oblique recession was helpful in these patients to correct the deviation. This patient of third nerve palsy, because of trauma, needed a surgery which was lateral actress recession with medial actress recession and inferior oblique recession, did very well after surgery. This is a special case very close to my heart. This was a heavy eye syndrome where there was a hypertrophy of 30 base up and 30 base out, and there was restricted elevation, and when we were doing surgery we found out that there was no superior rectus in the.
Saurabh, may I request you please?
Yes, ma'am. This is last case, ma'am. So what we did was identified that the superior rectus was missing. So the surgery was on table. We did a modified NAPS to this patient and we got a very good result. There are so many others, but thank you all for the presentation. And I will end up with this particular case. This case very commonly comes to us, and this is not a squint. This is basically a pseudo-exotropia because of the telecanthus. Thank you, ma'am.
Thank you, Dr. Saurabh. That was a nice presentation.
Dr. Saurabh, I just want to ask you one question. So do you plan your surgery anything different for decompensated cases of accommodative esotropia from that of acquired esotropia? Is there any change in the surgical plan for both cases?
Decompensated esotropia means the patient is getting esotropia.
So patient who was well orthophoric with glasses and suddenly present with the esotropia and it persists.
Acute esotropia which persists with time.
Yes.
So initially we have to wait, give some.
But that is persisting.
Yeah, that is persisting. So similar to that of acquired esotropias.
They are similar to acquired.
No.
Thank you. Next, we call upon Dr. Tania Modgil. She is going to present on management of fungal mass confined to the preseptal region of an immunocompetent patient.
Good morning, everyone. So I will be presenting my case on management of fungal mass in a 37-year-old. So this was a 37-year-old male who presented to us with a painless swelling in the left lower lid for last 6 months. It was progressing in size and there was no history of any other recurrent swellings, trauma, surgery, diabetes, hypertension, tuberculosis or any other disease. So he was an immunocompetent person who has suddenly presented with a painless from last 6 months only. So the swelling in the left lower lid, it was in the preseptal region when we inspected it, and when we palpated it, it was firm, it was mobile and it was non-tender. There was no bruit. The eye examination, rest of the eye examination was totally within normal limits. The visual acuity was 6.6, N6, both eyes, and the interior segment and the posterior segment were both within normal limits. Extraocular muscles were also normal. So diagnosis of a cystic lesion in the preseptal region was made. So potential diagnosis, we thought why it is that firm to the, specifically when we touched it, it was very firm to hard to touch. So we went for a cyst of a bacterial origin, tuberculoma as a differential diagnosis, or orbital lesion of unknown origin. So, so as we proceed with any other swelling, we went for a CT. The patient could not afford an MRI, so he went for a CT. And also we went for a FNAC. The FNAC showed that there was inflammatory exudate and there were fungal hyphae present in the mass. And the CT showed that there was a well-defined preceptal region, well-defined complex cyst in the preceptal region in the left lower lid with the extension to the inferior aspect of the left orbit, abutting the lateral inferior rectus muscle, and they suggested histopathology for the same. So we went with a subciliary incision, and as you can see there is a whitish mass which was even bigger than what was there in the CT. So subciliary incision was done and the cyst was isolated. We aspirated certain amount of pus which was white, totally white and thick, so that we can reduce the size of the mass, and the excision biopsy was sent for histopathology. Fungal cystic lesion was confined to the preceptal region in an immunocompetent person, and the histopathology report showed markings of for a chronic infection. It came out to be aspergillus. So discussion, the extracorneal space, as we all know, contains fat, blood vessels and sensory nerve endings. Common lesions which occur in the extracorneal space are schwannomas, cellulitis, lymphoma or any other infections. So bacterial pathogens are common, but invasive fungal infection, though rare, are critical, especially in immunocompetent and diabetic patients also. We have seen all the COVID era where we have seen different type of cystic fungal infections which were occurring, but this was a rare case which presented now. Hemangiomas, rhabdomyosarcoma, tuberculoma and abscess often linked to trauma or surgery are found. Fungal infections mostly are linked to mucormycosis and aspergillosis. Aspergillosis was the case which was in our patient. So non-invasive aspergillosis mostly occurs in immunocompetent patients as fungal balls or allergic sinusitis. So management includes surgical debridement. Surgical or antifungals are, oral antifungals are not mostly used, but we did give it to our patient because he was really worried that it may reoccur. So this case is basically a rare instance of fungal granuloma in the preceptal region of an immunocompetent patient, and we emphasize the diagnostic challenges and the importance of culture testing for every FNAC should be done. Awareness of fungal infections of preceptal region is important, and early surgical excisions with oral itraconazole is what we recommend. Thank you.
So Dr. Saab, I have a few comments.
Yes.
So you said it was a preceptal.
Yeah, sir.
So preceptal means it hasn't gone into the orbit.
Yes, sir.
So why are we discussing orbital lesions?
Yes, ma'am. I agree, but in the MRI, in the CT
exactly.
Showed,
I was coming to that.
Yeah.
That your examination missed out a very important point, which was the hypoesthesia on the face.
Yes, sir.
So that should never be missed, right? So that is a very important point. Second was that if you see that MR carefully, the maxilla of that side has the lesion.
Yes.
So it is not purely preceptal, right? And my third comment was that I see in your surgical photograph that you've held the tissue with an Alice forceps.
No, ma'am.
You've held the skin tissue with the Alice forceps.
Yes, ma'am.
Now, Alice is not that, if you are an oculoplastic surgeon or talking of aesthetics, I would suggest that you keep a single fine muscle hook.
Okay,
see, the plastic surgeons have this very beautiful instrument.
Yes,
it's a very fine hook. So just elevate it with that, and in case you don't have it and you're a strabismus person, then you can use your simple muscle hook for that.
Okay.
See, Alice is going to be very traumatic to the
Yes, ma'am,
skin.
I agree. Yeah, I agree.
That was my comment. Thank you.
Thank you, ma'am.
So now we have Dr. Pushpinder Kaur for her presentation.
So I'm going to speak about something which nobody is really paying attention to, and after the oculoplastic people have done their job, they've done wonderful surgeries, wonderful jobs. The patients don't know how to get rehabilitated. So I'm going to talk about that. Changing lives, restoring smiles, customized ocular prosthesis for aesthetic and emotional rehabilitation. So eyes are not just the organ to see the beautiful world. Rather, they are also created by God to make the face beautiful. Once one eye is lost due to any reason, it leaves behind unfathomable physical, mental and psychological agony and trauma. The person cannot hide his eyes behind dark glasses forever, and he is looking for his vision to be restored. When he becomes unsuccessful in restoring his sight, he still desires cosmesis. There are situations when blind, ugly looking eye is bigger or smaller than the other, which makes the face look very asymmetrical and ugly. Here comes the role of oculoplastic surgeon to create symmetry, surgically increasing and decreasing the volume in addition to some additional procedures like deepenings, superior and inferior fornices, blepharoplasty, canthoplasty, etc. An ocularist who makes the customized ocular prosthesis, artificial eye, from powder to the end product by his art of painting, matching, 3D anterior chamber creation, iris color matching, etc., to the extent that not only the general population, even sometimes the trained ophthalmic staff misses it at the first glance. There are numerous stories of which unfortunately people had to live in agony just because of the shattered self-esteem because of bad or ugly looking eyes. Akal Eye Hospital started oculoplasty and ocular prosthesis in the year 2000, and during this time the hospital has changed such people regain their confidence, self-esteem and thus change their lives. I will share some of their stories with you. Now aged 25, lost her eye 10 years back due to firecracker injury. She refused to go to school or even get out of the house, but regained her ocular confidence after evisceration with orbital implant and customized ocular prosthesis. Aarti, age 23, lost eyes 8 years back due to two-wheeler road accident, regained her cosmesis and thus beautiful looking faces after evisceration, orbital implant and customized ocular prosthesis, and now she is happily married. Rahul, aged 8 years, lost his eye with trauma with a pencil. He went into phthisis and he refused to go to school as he complained that his fellows made fun of his ugly looking face. Dermis fat graft increased the orbital volume, which was followed by customized ocular prosthesis were done, and Rahul happily rejoined his classes. Parminder Singh, 31, had injury in Dubai and lost his eye. He had difficulty in his matrimony due to unsymmetrical face. Customized ocular prosthesis was done and he got married after 6 months, and he even invited me to his marriage. Raj Rani, aged 80 years, lost her vision post cataract surgery and ophthalmitis, which later went on to plain full blind eye. She was treated with customized ocular prosthesis and also made her face beautiful. So
खोलो,
just showing.
बंद करो, खोलो, सज्जे पासे देखो, खब्बे पासे देखो, सज्जे पासे देखो, खब्बे पासे देखो, ऊपर देखो, नीचे देखो, सीधा देखो, सज्जे पासे, खब्बे पासे, ऊपर, नीचे, बंद करो आँखें, खोलो.
So this was just showing that we do get some amount of ocular movement, and we try to keep the in the primary gaze and give slight movement whatever we can, so that it helps in patient satisfaction. There is a misconception that cosmesis and desire to look beautiful is concerned of just younger people, but at Akal Eye Hospital we get patients from all age groups, economic strata and cultures. There are few stories of fortunate people who visited us and got their lives changed, but there are hundreds and hundreds of such people who are rehabilitated by customized ocular prosthesis socially, physically and economically. So these are just the pictures before and after. Another one, another one, another one. This boy has now gone to Italy, and whenever he comes to India, he comes to see me and sometimes get new eye made. Thank you. So I just want to send this message that please do help these patients. They move all over without any relief. And point to add, I've got lots of patients from Jammu Kashmir, the people with pellet injuries who lose their eyes. So I've made couple of those, I mean not couple of them, quite a lot of those eyes. And now people there generally know that there's a doctor from Jalandhar who does this. I went there to Pahalgam. This is a little story since I have some time. So my friend had an argument with a person.
I have questions for you. I have questions for you.
Yes, okay.
So thank you for this very beautiful topic that you've approached, and definitely this is a world of work that you're doing. My main point to emphasize here is that an off-the-shelf prosthesis does more harm than good.
Yes, ma'am.
So it is extremely important that whomever you eviscerate or enucleate, please tell them not to use an off-the-shelf prosthesis. If they can't reach madam immediately, they should use a conformer and not an off-the-shelf prosthesis, because the material, the weight and the size are going to cause friction on the soft, supple conjunctiva. And that is going to lead to an inflammatory granuloma, which will later cause inferior fornix shallowing, sagging of the lower lid, and all those beautiful cases that she has done, they actually are not so simple. I'm sure you have a volume of patients where you have had to first create the fornix.
Yes, ma'am.
And then you give the prosthesis. Yes. So custom made is best given immediately after a good surgery. After the first week when the wound has healed. Until then, please put in a conformer so that the fornix keeps getting the message that there is place and it needs to grow. Thank you, madam. I'm really appreciative of this.
And that whatever madam has said cannot be overemphasized. I've seen people having ulcers and their eyes really inflamed and red, and people crying out in pain. So the stock eyes, as we call them, or the ready-made eyes, are very bad. Nobody should use them. Yes, as an alternative they can have conformer, but they should get customized ocular prosthesis made. Thank you.
I'll call Dr. Yashi Bansal for her talk on
a bit ignored topic in ophthalmology, that is ocular disorders in Parkinson's disease. So Parkinson's disease, as we all know, is a neurodegenerative disorder which is characterized by dopaminergic deficiency in the basal ganglia, and it encompasses both motor and non-motor symptoms. So the ocular disorders occurring in Parkinson's disease can be categorized majorly into three categories. The first one are due to degenerative process underlying the Parkinson's disease, that is due to dopaminergic deficiency, and these respond positively to dopamine therapy. The second ones are the ones occurring as side effect of dopaminergic, cholinergic or noradrenergic medications which we give in the Parkinson patients. And the third ones are the side effects occurring as side effect of surgical intervention like deep brain stimulation and pallidotomy, which are the surgical interventions for Parkinson patients. So what is the significance of identifying these visual disorders? So these visual disorders, they serve as prognostic factors for the progression of Parkinson's disease. Visual hallucinations, which are a type of visual disorder which is seen in Parkinson patient, is associated with a more rapid cognitive decline and is a significant predictor of dementia in such patients. So the use of visual cues such as stationary stripes pasted onto floor to alleviate freezing of gait, which is used in Parkinson's, this becomes difficult in these patients, and these patients, they suffer frequent falls. New rehabilitation strategies such as exergaming, smart glasses, telemedicines, they also fail to offer any help in presence of visual disturbances. So the presence of visual disturbances disrupts daily activities such as walking, reading or driving, and lead to decreased quality of life, as the patients with Parkinson's largely use visual cues to guide their movements. So timely recognition of these symptoms help in offering them independence and a better quality of life. So what are the various ocular disorders that are seen in Parkinson disease? They are majorly grouped into oculomotor disturbances and diplopia, glaucoma, dry eye disease, color and contrast impairment, visual hallucinations, visuospatial and visuoperceptual impairments. So in oculomotor disturbances, we have convergence insufficiency, which causes blurred near vision. Then there is upgaze limitation, abnormal saccades and smooth pursuits. So diplopia, the prevalence is 10 to 30%, and it is majorly categorized into binocular diplopia or selective diplopia, which is a specific type seen in Parkinson patient. So the binocular diplopia is often seen and is caused by eye misalignment. Common cause of binocular diplopia is convergence insufficiency, where the eyes struggle to turn inwards to focus on near objects, leading to an imbalance of the visual axis. Selective diplopia, which is distinctly seen in these patients, it is where isolated objects or people, they are seen duplicated and the patient does not always sees double. So this is thought to be closer to the mechanism of visual hallucinations rather than an oculomotor problem. So the incidence of diplopia is directly related to the disease progression, and diplopia can also serve as predictive factor for the occurrence of visual hallucinations. The treatment in case of binocular diplopia that is associated with convergence insufficiency largely consists of prisms and convergence exercises, while the selective diplopia can be managed by managing hallucinations, and addressing the hallucinations is actually helpful in these cases. Then the prevalence of glaucoma is around 16 to 24%. The glaucoma can be open angle, angle closure or normal tension glaucoma. The most common of these is primary open angle glaucoma, but the prevalence of high intraocular pressure is less in Parkinson patients. The pathophysiology of glaucoma here is due to progressive retinal dopamine depletion leading to the retinal degeneration, or the alpha-synuclein mediated axonal degeneration, which is common in both glaucoma and Parkinson patients. The investigations are the usual ones which we do for glaucoma, that is fundoscopy, IOP measurement, visual field analysis. Treatment consists of topical anti-glaucoma drugs. If the patient does not respond, then laser trabeculoplasty can be done. But since the basic underlying mechanism is dopamine deficiency, so levodopa therapy can improve some visual aspects. Dry eye disease prevalence is 53 to 60%. The pathophysiology is decreased blink rate, which is a classical Parkinson symptom, which leads to decreased distribution of lipid components of tear film over cornea, leading to faster evaporation of the aqueous layer. Autonomic dysfunction, which is seen in Parkinson disease, also contribute to this, as lacrimal gland is partially innervated by parasympathetic autonomic supply. So the treatment consists of artificial tear drops, omega-3 or 6 fatty acids, punctal occlusion, temporary or permanent can be done. Color and contrast impairment, exact prevalence is not known, but the most commonly seen ones are blue, yellow and red-green deficiencies. The pathophysiology consists of impaired processing of visual stimuli due to deficiency of retinal dopamine. Treatment consists of dopaminergic therapy and prescribing yellow filter glasses or selective absorption glasses to the patient. So visual hallucination, they occur early in the disease course in Lewy body Parkinson, which is a specific type of Parkinson disease, and helps differentiate this type from the other types. So the prevalence of visual hallucination largely ranges from 4% to 82.7%. These comprise of simple illusions like misinterpreting a quote as a person to complex, vivid or formed hallucinations of people or animals. So the visual hallucinations underlying cause is thought to be a nerve cell loss and Lewy body pathology in specific areas of the brain that affect vision. Visual hallucinations are more common in patients, those have dementia and are associated with the accelerated cognitive decline. Anti-Parkinson medications, especially dopamine agonists and anticholinergics, serve as significant triggers for visual hallucinations occurring in these patients. Other health conditions such as infection or dehydration can also act as triggers. So the medication adjustment forms a very important aspect of treatment in case of visual hallucinations. Reducing or changing the anti-Parkinson medication can help, and prescribing atypical neuroleptics like quetiapine or pimavanserin can be helpful. Then we have visual spatial and visual perceptual deficits. These impairments are linked to structural changes and atrophy in the posterior temporal and parietal cortex, and dopamine deficiency contribute to these problems. So in conclusion, the neurologist or the treating physician should be vigilant about the ocular disorders occurring in these patients, because patients don't recognize ocular symptoms as a part of Parkinson's disease diagnosis and don't report themselves. Ocular symptoms can be treated with ophthalmological intervention or optimization of dopaminergic therapy. Dopaminergic medication, deep brain stimulation and pallidotomy can contribute to the visual problems, hence a closer evaluation is required while switching from one mode of treatment to other. So in the end, I would say that data on ocular disorder in Parkinson is largely lacking. So a lot of research needs to be done to improve the quality of life and offer independence to these patients. Thank you.
I'm sure a lot of us don't have this experience that you have, because you need to work with in a big hospital or somewhere where there are a lot of neurological patients. But good that you took up the topic.
Yes, ma'am.
Thank you.
Is the incidence of this glaucoma actually high in such cases, or is it the same as it is found in senile patients?
Sir, the incidence of glaucoma is around, like I said, 25 to 40%, but the incidence of high intraocular pressure is not there.
Is not. So it means it's a case of
the intraocular pressure remains low because the glaucoma is due to dopamine deficiency.
Dopamine. So it's basically normal tension glaucoma. We can say that it's ischemic component which may be responsible. Yes. And secondly, how you just mentioned that diplopia sometimes serves as a factor for visual hallucinations. They are predictor of disease. How we differentiate and how they are helpful in such cases?
Sir, if visual hallucinations are present, if patient is reporting visual hallucination, then patient has more chances of developing diplopia.
Is it actual true diplopia, or is it visual hallucination, which is more common in such cases?
So visual hallucinations, like I said, the incidences ranges from 4 to 82.7%, and they are more common in Lewy body Parkinson disease.
Okay.
So it's like some patients can have more of.
So is it true diplopia?
Yes, it's binocular or selective diplopia.
Okay.
So monoocular diplopia never occurs in Parkinson.
That is not there. And the cause of binocular diplopia will be?
So convergence
insufficiency.
Yeah. Oculomotor disturbances are there, so that leads to the binocular.
Okay. Right.
Thank you.
So Seema, can we invite you for your talk?
प्लीज वो पक्खे चला दो, पक्खे कूलर व्हाटएवर
बिल्कुल ही बंद कर दो
सब कुछ
सफोकेशन
that's why they are so yeah वो भी बंद कर देते ना पर्दा वो भी बंद कर देते डिस्प्ले.
So I'm going to talk about a very common problem but often neglected by us in practice. Centration of spectacle lenses is a crucial consideration in the satisfactory dispensing of spectacles. Proper alignment of the optical center with the visual axis ensures optimal visual performance. So frame selection, prescription accuracy, lens material and design, and facial anatomical characters can affect the centration of spectacle lenses. So this is a common scene that we see, the glasses sliding down the nose. We may have chosen the right frame, but if we used a high index glass, the glasses will tend to slide over the nose, and that will misalign the centration. So decentration refers to the displacement of the optical center of the spectacle lens from the patient's visual axis. It induces a prismatic error in the lenses, which theoretically can be tolerated up to 1 to 2 prism diopters. So just revising the Prentice's rule, which states that the prismatic effect at any point on a spherical lens is equal to the distance of the point from the optical center of the lens measured in centimeters multiplied by the power of the lens. So PD is equal to C multiplied by F. So more the decentration, higher the prismatic error, and more the power, again more the prismatic error. So a base in prismatic error is induced if a convex lens is decentered nasally, or if a concave lens is decentered temporally, and base out prismatic effect is induced if a convex lens is decentered out and a concave lens is decentered nasally. So this picture shows how a spherical lens can act as a prism if decentered. So this is the effect, that a patient is not actually looking through spherical lenses but through a prism. So the consequences of lens decentration can range from mild visual discomfort to significant visual distortion and decreased visual acuity. Patients may experience symptoms such as blurred vision, headaches, and eye strains if the lenses are not properly centered. So these are the symptoms so many of our patients are coming and telling us, but are we looking at the centration? Are we getting the centration done properly? Are we sending them back to the optician for centration? I don't think most of us are doing that. Moreover, because of the prismatic error, there may be a slight movement of the eyes, which can affect the aesthetic appearance of the patient. So we conducted a study on 150 students, and the key inferences from the data was that the frequency distribution of asthenopic systems shows that a significant portion of participants experience mild to severe symptoms such as headache, eye fatigue, blurred vision, eye strain, and burning sensations, especially for near work. Those severe symptoms such as double vision and flashes of light are less prevalent. So many of our patients who are coming to our OPD, ji, ऐनक तो लगा ली पर दिसदा नहीं हल्ले भी ठीक, थकियां रहंदियां अखां, सिर दुखदा. So it may be a decentration problem. So the study findings are consistent with the literature which suggests that decentration can lead to asthenopic symptoms and discomfort in spectacle users. Although the mean IPD and OC measurements indicate that the spectacle lenses were generally well centered, but a significant proportion of patients still experience mild to moderate symptoms, especially related to near work. So all of us who are doing a lot of near work, students, academicians, doctors, our glasses should be very well centered. And the observations are as per the NSI standards, which suggests that individuals can tolerate up to 1/3 of vertical decentration and 2.5 millimeters of horizontal decentration without symptoms. However, even minor decentration can contribute to spectacle intolerance and discomfort, especially during prolonged near work. So what are the solutions? Precise measurements are the key to give a properly centered glasses. Frame selection should be done properly, and now there are digital centration devices which ensure proper centration of glasses. So thank you.
So thank you, Dr. Seema, for touching this important topic, and I think I can see people from the next session walking in. So the last talk is mine. We'll cut down the discussion. You can have it for lunch.
Best for the last. Understanding thyroid associated ophthalmopathy, which is very important,
Can you please put it
Dr.
on?
Abjit Kaur.
So at the outset, I'll say that I chose this topic because very often we miss what is mild thyroid ophthalmopathy. Glaring eyes, retracted lids, this is no rocket science. Everybody can diagnose Graves' ophthalmopathy. The issue arises when we do not see any obvious signs. So that is why I picked up this topic, and because of paucity of time, I'll quickly rush through it. Please move the slide. So we all know that thyroid ophthalmopathy is an autoimmune disease, and it is the antithyroid immunoglobulins actually which are the crucial players in this disease. The tissue is, this is not moving. Can you please permit it to move?
Yes,
yeah.
It's moving.
So it's an intriguing disease because it varies, the whole clinical syndrome varies. You can have euthyroid, hypothyroid, hyperthyroid. All the hormone levels can lead to this. There is no direct correlation between the control of the disease and the control of the thyroid ophthalmopathy. And there is a strong impact on the psyche of the patients. Smoking, we know, is an important risk factor, and the other risk factor is life stress. Life stress, why have I put it in red? Because all the others actually lead to life stress. And this is a little thing which I got up from the book, which just shows that the thyroid stimulating immunoglobulin is the one actually that causes all this trouble of growth of fibroblasts and all. And because it is an autoimmune disease, other autoimmune diseases should be looked for, like myasthenia gravis and Addison syndrome, vitiligo and pernicious anemia. Interestingly, Yersinia enterocolytica infection of the GI tract has also found an association with tau. Clarithrine-mediated signaling pathways, the palmitate pathway, and the thyroid 1 surface markers are all there. So the concept of severity and the concept of activity, these are two important concepts. I'm not going into detail. The disease follows the Rundle's curve, which means that there's an active phase and then subsequently it plateaus. So I like to address this disease in 7 commandments. The first is that the lid should be your guide. Age, laterality, site of involvement do not matter. And the surrounding skin shares the burden of the disease, which means that there is upper lid retraction, there is temporal flare, there is lag on down gaze, there is eyelid fullness, there is incomplete or infrequent blinking, and there is resistance to downward pulling of the retracted eyelid. Why is this important? Because when it is happening because of just sympathetic overstimulation, you will be able to pull down the lid. But when it is a fibrotic lid which is retracted, you will not be able to pull it down. There are absent lid creases on the forehead. This is very often missed. And glabular rhytids again. People think that this patient is used to frowning. No. Many times it is associated with an underlying disease. That doesn't mean that everybody who is frowning needs to go and get a T3, T4, TSH done. Look at the whole patient in totality. The second commandment is that the ocular surface partakes in the disease. Do not miss the corkscrew vessels, do not miss the exposure keratopathy, do not miss the chemosis. And the superior limbic keratoconjunctivitis is, incidentally, for everybody's knowledge, it's a prognostic factor now in the management of thyroid ophthalmopathy. We have seen patients who have lost their eye even though there was no exposure keratopathy because of the underlying primary corneal involvement of the disease. The third is that extraocular muscles demand attention, both in action and in visualization. Action, of course, you will get to know clinically, but visualization is important because the patient may be asymptomatic, just a dry eye or just a pain in the orbit, like dull aching pain behind the eye. So currently the absolute diffusion coefficient has become a very sensitive tool in my thyroid eye clinic. Every patient undergoes an MR with a calculation of the ADC values as a baseline. The fourth commandment is that do not underestimate the soft tissues, both in active disease and in healed severe disease, because it is the fat and the facial scaffolds which give rise to most of the presentations. The first wall, the concept of the first wall is that now decompression is done by removal of fat and not by bone. The facial scaffolds, of course, are very important. Fat is seen as enlarged on CT scan, on MR, and the dilated superior ophthalmic vein is very important. Why has it stopped moving? The fifth commandment is that don't neglect the lacrimal gland, both clinically and radiologically. We know that there is aqueous deficit dry eye in tau, and the lacrimal gland prolapse, of course, can often be thought as a fat pocket on the lid. So look at the scans very carefully. The sixth commandment is that tight space is called compression. The compressive optic neuropathy, of course, is the really danger sign of thyroid-associated ophthalmopathy. But don't forget the secondary glaucoma in cases of healed fibrotic thyroid ophthalmopathy. The disc may be hyperemic, there is visualization which may be difficult because of the corneal involvement that has happened. So have a high index of suspicion if there is diminution of vision along with pupillary involvement. Apical crowding and straightening of the optic nerve are important radiological signs. Compressive optic neuropathy, of course, can be very easily seen on scan. And a rise of 8 millimeter or more on up gaze should raise an alarm. But do not sit back in a patient of tau, because this disease is dynamic. What is simple today may become complex. And based on so many of my research theses, I have sort of summarized that the quality of life improves significantly after treatment at all stages of the disease. It correlates directly with the oxidative stress, and these markers never reach the normal baseline, even if you do not have any evident marker. ADC is altered even when the conventional MRI is normal, and pre-perimetric damage of retinal nerve fibers is detectable on OCT. Avoid getting patients like these who had been visiting the doctors several times but ultimately became blind. Thank you for your kind attention.
Thank you,
Any
ma'am.
questions? I try to stick to my time.
Yes.
Thank you, ma'am. That was a excellent talk. All of us, I'm sure, benefited so much from it. So, any questions?
Ma'am, in how many cases of thyroid ophthalmopathy do the symptoms, all these lid signs and this proptosis, lid retraction, they subside after starting the therapy, after the patients become euthyroid?
If you saw my slide carefully, I had very categorically said that the curve of the thyroid eye disease does not follow the
that
curve
of thyroid disease.
So there is no way of predicting. So that is why in my practice, I have now set up, practice means I work at the King George Medical University. I have started a separate thyroid eye clinic once a week, so that patients who, and plus it's a multi-speciality clinic now. So we liaison with the immunologist, we liaison with the endocrinologist and the radiologist to be able to give a patient-centric approach. So there is no way of predicting how the eye is going to behave despite your treatment. Yes, IVMP definitely has a very important role in case there is active increase in proptosis or there is active diminution of vision.
Triamcinolone injection around that area?
I have stopped using triamcinolone because I found that this local anti-inflammatory action of triamcinolone doesn't last. The body literally washes it off within 2 months, and after 2 months the patient is back. If I'm sure that this retraction is because of tau, I rather do a mullarectomy once the retraction is stabilized. In the meanwhile, I prefer to do a low dose of Botox.
Okay.
To get the lid down.
Thank you.
Should we plan squint surgery in such cases? For how long should we wait rather for squint surgery in such cases?
The dictum is that once the orbital disease has become quiescent, you have followed this patient for at least 6 months of quiescence. Because this muscle is going to fibrose.
Yes.
And fibrosis, till it stabilizes, you will not do any squint surgery. Because your results will change. Anything else? Okay, we call it a day. I think everybody is sweating.
Yes.
Lovely being with all of you. Thank you.
Thank you.
Everybody come for the photograph. You call the photographer, please.
Never mind. Sarah, aap le lo, you take a photograph and I'll send it to Shika and she'll send it to him. That's my son.
Please, आप भेज दोगे? चलो ठीक है, आ जाओ आगे आ जाएं. चलो. Can we get through this?
Yes. मैं भी निकल जाऊंगी.
मैं निकल जाऊंगी तो आप निकल ही जाओगे.
Sorry, I want to.